I would like to invite our first panelist, Dr. Suvin Sethi sir. He has done his MD pathology and DPB from Mumbai University, Maharashtra, and he has several management and quality accolades to his name. Let me name few. Certified in healthcare risk management by CAHO and ASQA 2021, hospital management program by Indian Institute of Management, Ahmedabad, and certified internal auditor on WHO patient safety friendly hospital standards, and he is the NABL assessor, and he has several professional affiliations to name few here. Vice Chair, Quality and Healthcare Professionals Wing, CAHO, and ex-Honorable Secretary and Association of Practicing Pathologists in India, and Indian Association for Pathologists and Microbiologists, IAPM life member, and Indian Society of Hematology and Blood Transfusion, ISHBT life member, and currently working in Dr. L.H. Hiranandani Hospital, Powai, as a full-time consultant, a pathologist, and head Department of Laboratory Medicine. And I would like to invite our second panelist, Dr. Saurabh Raha. Is an eminent personality and leader in quality, and also a organizing secretary for this event. And he has a postgraduate diploma in hospital administration, hold a master degree in quality from the UK. And Dr. Saurabh is a NAB's assessor, and currently is the vice president in quality, Yasoda Super Specialty Hospital, Ghaziabad. I welcome you, sir. Over to you, sir.
Thank you, Mr. Monivakam, sir. I now welcome our two expert panels in our expert panel decision. And we have first Dr. B.K. Rana. Dr. B.K. Rana, as everybody knowing, is the CEO of Quality and Accreditation Institute and a former director and CEO in charge of NABH, who has more than 25 years of experience in quality and accreditation. He is the founder member of International Academy of Quality and Safety, member of Scientific Board, International Alliance of Patient Organization, board member of International Society of Telemedicine and E-Health, besides being the chairman and documentation review committee and member of Complaint and Appeals Committee of National GLP Compliance Monitoring Authority, Department of Science and Technology, Government of India. Besides this, he has been a former board member of International Society of Quality and Healthcare, a board member of ISQA, that is the International Society for Quality and Healthcare External Evaluation Assessment, former president of Asian Society for Quality and Healthcare, and former chairman of ISQA Accreditation Council. Now moving to the quality, I have from the clinical field, Dr. Narayan Prasad, our next expert, who is the professor and head Department of Nephrology, SGPGI, Lucknow. Sir is the Honorary Secretary, Indian Society of Nephrology, member, South Asian Regional Board, International Society of Nephrology, former Secretary, Indian Society of Organ Transplantation, former Secretary of Peritoneal Dialysis Society of India, and former Treasurer of Indian Society of Nephrology. I welcome you both, sir, for our expert panel. And I would start with Dr. Narayan Prasad in having his views in how does he start patients on hemodialysis in case of end-stage renal disease. Dr. Narayan Prasad, sir.
Thank you very much for this opportunity to be making me the part of this panel discussion. First of all, we all understand that we start dialysis in a patient of end-stage renal disease or patient with an advanced kidney injury if there is acute kidney injury also. So both kind of things. But today I am going to talk about patients of end-stage renal disease who requires dialysis. Basically, we all understand that there is a certain level of the GFR below which we call them end-stage renal disease or end-stage kidney disease. That GFR is 15 ml cutoff. But many times we observe that the 15 ml GFR is very good GFR to maintain the life without dialysis. So every patient on that cutoff value of the 15 ml GFR do not require dialysis. So if your GFR is less than 15 ml, but condition should be there of the symptoms of uremia. If you have less appetite, you have nausea, you are not eating well, you are not feeling well. If you have all symptoms of uremia, then we should think of putting this patient might be the suitable candidate for dialysis. So that is my first argument, that not every patient who has been declared interstitial renal disease having the GFR of the 15 ml require dialysis. Majority of the time, we require dialysis when your GFR comes at around 5 to 10, between 5 to 10 ml of GFR if you are symptomatic. So that is important, and that patient himself should also consider whether he is feeling well or not, whether he is eating well or not, whether he is losing weight day by day, he is getting malnourished day by day. So that thing should always keep in mind. That is the patient perspectives. So that is from my side for these questions.
But what parameters do you follow in such patients on hemodialysis?
Actually, when we put the patients on the dialysis, then again comes many times many of our experts are talking about the adequacy of the dialysis. So adequacy of the dialysis has two important parameters. One important parameter is the objective value of the KT/V urea. So that you are getting or not. So that gives you some objectivity. The most important parameter, what I feel, at what amount of the dialysis your patient is feeling well, whether the patient is eating well, patient's body weight are well maintained, patient hypertension is well maintained, he is not getting malnourished. So that is another important parameter. He has no continuous metabolic acidosis. His CKD, MBD parameter, what we tell about the calcium, phosphorus, alkaline phosphatase, and PTH values are within normal limit. So every patient do not require equal amount of the dialysis. That is another important thing. If the patient initially has very good residual urine function, patient can do well when twice weekly hemodialysis. Sometimes, if the patient's urine output is totally nil, they are not doing well, twice weekly hemodialysis is not enough for him. Try to maintain these patients on increasing amount. So what we call about the incremental dialysis. Maintain these patients on thrice weekly dialysis, even sometimes the hemodiafiltrations and other modality of dialysis is required. So what is more important?
Dr. Narayan Prasad, sir, we cannot hear you.
Not listening?
Now your voice is clear.
What I am trying to tell, it is very important for any clinician looking after these patients on the dialysis, and the patient himself should also think of whether he is doing well, he is feeling well, he is eating well. Adequacy parameters does not mean only the KT/V urea. Education, this parameter is the patient's well-being, whether patient is eating well, CKD, MBD parameters, what is called about the calcium, phosphorus, alkaline phosphatase, PTH level, these are within the normal limits on the regular checkup. That are the important, they are not getting malnourished. So these things should, blood pressure is well controlled on the dialysis. It is not that the patient is coming every day in the dialysis unit with the volume overload. Blood pressure is always elevated, is not controlled. So every parameter, comprehensive, all clinical parameters should be monitored on each visit. So that is so-called the adequacy of the dialysis, and that we should look into day-to-day practice.
Thank you, Dr. Narayan Prasad, sir. My next question is to Dr. Rana, sir. How do we ensure quality and patient safety in a dialysis center?
Okay, thank you. Thank you, Dr. Raha, for the question, and thanks, CAHO and CQE for having me here today, this evening. And so far, excellent presentation by all the speakers. I was really and thrilled by getting all the conversations and information was provided there. So thank you all the speakers. Now, when you ask that how to ensure quality and patient safety in a dialysis center, the question comes back to everyone is what we do mean by quality. If we understand the meaning of quality, then of course we will be able to move forward to define what we should be doing. So if you ask me that what quality means, that it has different meaning for different purposes, for different individuals and different organizations. If I say that for me, quality is that I am doing things as I am supposed to do. And what I'm saying I'm supposed to do means what I have come to know through evidence-based practices, like just Dr. Narayana mentioned, giving his practical experiences into it, that what is right for the patient. If I'm doing that right for the patient is I'm doing the quality work. In essential, what we can say is if an organization, in this case here, the dialysis unit or center, has the required resources available to them. What is the meaning of the required resources? Required resources mean man, machine, environment. Mean the proper numbers and qualified human resources, proper infrastructure, it may be physical infrastructure, equipment available for the functioning of the dialysis unit, and the third component is the environmental conditions, right? That whatever environmental conditions are required, if you need to maintain a specific temperature, specific humidity, sterility, all those should be maintained as they should be. So availability of all type of resources makes things happen in a way they should be happening, right? Now coming to the quality of the second part, which is linked to the patient safety. The quality is actually an umbrella objective of any organization. Anything can be linked to quality. People usually get misunderstanding that if they are accredited, if they get accreditation, they achieve quality. It's not necessary. Accreditation is one such tool to achieve quality, right? So it's not everything that you achieve accreditation and then you end the history. No, it's not. So second component when we link with the quality is about the patient safety. What does it mean? The patient safety means there should not be any harm to the patient, which is very much preventable. Okay, preventable harm should not be happening to the patient, which are happening around the globe every day, every hour, every minute, every second. So our responsibility as a dialysis center should be to avoid any harm which is not to be happening in the patient. In the end, ensuring the life of the patient, ensuring the credibility in the treatment, ensuring the better outcomes for the patient. It is a well-known fact that the doctors will try to provide the best care. The nurse would try to provide the best care she or she can provide. Despite that, errors are happening in different stages of treatment protocol, which are being received by the patient during this stay. So in essential, in the end, what we say, if we are doing our job as we are supposed to do, which means we have things documented, we have the procedures, we have the protocols, we have required infrastructures, we have required manpower, we have all adequate resources, and we are making use of them optimally, so that at the end, the patient which are receiving care in your dialysis center remain safe. Something clinically happened, that's not in your control. You are trying your best to provide clinical care, but the harm, medication errors, right? Wrong medication, wrong route, wrong dose to wrong patient happening. These are very much preventable. These are not something which you can't prevent. You can prevent, right? Use of dialyzer without cleaning it properly, and we were talking about the reprocessing and how many times it can be used. Dialysis machine, RO water. If there is an infection in there, you are not checking it properly, then it's our responsibility. So to give the final line on that, to ensure quality and patient safety in a dialysis center, a dialysis center should follow documented policies and procedures. They should employ qualified and trained manpower. They should have adequately maintained and calibrated equipment and sufficient environmental conditions to be made available to that. So I think if we do that, our job is done to ensure quality and patient safety in a dialysis center. Thank you.
Thank you, sir. So, but what are the challenges you see in maintaining quality in dialysis centers, and how Quality Accreditation Institute are supporting quality improvement activities in dialysis centers?
Thank you, Raf, for this question. And I think I would quote the last point in the presentation of Dr. Vinoy. His last point, the dot point, his presentation was accreditation of unit should not be the final objective. And I like that statement very much. And this is what it is actually, that how we can ensure the continuous maintenance of quality and safety in our centers. We should not be just seeking that we get accreditation, or we just want to get accreditation, we got accreditation, and our journey finishes, our journey ends. No, it's the beginning of your journey actually. So the challenges which we face and which I come across while we talk to the people is that it just become a sort of preparation. For a few times, you prepare, you achieve some objectives, and then you just become liberal. You don't continue working towards those goals and objectives as you have been working in the past. So I think the most important challenge is the continuity. The continuity in all things, everything what we are doing. Every procedure which we are following is not the one time you follow a procedure, next time I'm not. Once a day I'm washing my hands and cleaning my hand, and not the second time. It's not the way we can. So the challenge is to maintain the continuity of the policies, procedures, implementing aspects of anything which we have. So most important challenge is, again I'm telling it, to maintain the continuity of the practices which you have implemented in your dialysis center. What we are doing at QAI, as I thanks Dr. Gupta in his presentation, he highlighted that QAI has developed accreditation standards for dialysis centers, right? Both at a standalone dialysis center or a hospital-based dialysis center. And these standards are internationally recognized by ISCO accreditation, right? So this is just one step that, yes, if anybody is interested, they can go for accreditation to improve, to learn from the standard. And I'm not just saying that you go for accreditation. You just take the standard, use these standards. Use these standards, implement these standards in your dialysis center, practice these standards in your dialysis centers. And if one day you like to go for accreditation, you can go for accreditation. But your target should not be, as Dr. Vinoy mentioned, to achieve accreditation only, or to get a certificate and hang on the wall. No, your journey should be starting from there, right? So we at QI is trying to build that comfort level into the dialysis center, that you take the standard, use them, make yourself comfortable in implementing those standards, right? Second thing, what we are trying to do is trying to create awareness around it, because many times we are the people who really want to improve, but they are not aware of. So we want to reach out to those people who or organizations who are really interested to improve, to make their patients' life better, more safe care they want to provide to their patient, in creating awareness. So we are creating awareness. We are doing a lot of we call it one Saturday, 1 hour on a Saturday. Every Saturday we are doing one awareness on a one specific standard. So I think that the challenges can be overcome, very clearly overcome, because we have the passion. I can see the speakers which they were talking about on the topics with so much of passion and commitment that things can change if we are really passionate about it to make it change. So I think from my side, I would like to say that organizations and individuals, they should continuously improve by practicing the standards, not just one time taking it as a one-time activity. It should be evolving over a period of time. You should take it like in a riding on a staircase, one by step, until you reach to your destination. You are not taking rest. And in healthcare quality, there is no resting place. You have to continuously work, evolve, and improve. Thank you very much, Saurabh.
Thank you, Dr. Rana sir, for your insights. And thank you, Dr. Narayan Prasad sir, also for your results. I would now request Dr. Subin sir to take the dais and address the questions as put in the question and answer box.
Thanks, Dr. Saurabh. In fact, I'll request all the faculty, if they are available, to come on board on the panel. We have a few questions which has been posted by the audience, and quite a few have been answered and very well answered, because I see 2-3 answers to that. I mean, that's phenomenal, because any question will have 2 or 3 aspects of it, and we are getting that kind of a response from the faculty to the queries that has been raised. So I'll like to start off with the first speaker that we had, Dr. Prasanna. Dr. Prasanna, there was one question. I think it has already been answered, though, since it was there for a long time. I'll request you to answer. It was a question from one of the audience member. Can we have a dialysis center in the basement with stair ramp and lift facility?
See, I think there is no restriction as such, but the point is we'll have to go with whatever the building guidelines are in that particular city, with respect mainly to fire safety and evacuation plans. So as long as, see, there are some cities that do not permit usage of basements for clinical facilities, barring only for radio diagnosis. I mean, for example, in Bangalore. So we need to go with that respect, primarily because of the concern of fire and evacuation. So I think we go by the laws of that particular state.
I completely agree with you. I think there's law of the
but it is preferable. It is preferable if you have they have written as a ramp and stairs. Without a lift, sometimes it becomes difficult, because the ramp to push the patient in an emergency or to get a patient in an emergency, access is an issue. So long story short, without a lift, without appropriate things, it becomes a difficult things to do in basement. The other point is when you have so much of water, there is a problem of storage. There is a problem of pumping the wastewater and sewage. There's also a problem of where you keep the RO plant. I mean, a lot of things. So not an ideal situation.
Thanks, sir. In fact, Mr. Jayaraman wanted to interject.
No, I think Professor Prasanna has already answered it. Done.
So one more question with regards to the first session was about manpower. I think the question was how many machines one tech should handle at given point, at a given time?
2 to 3, definitely not more than 3. But the point is you at least need to stagger the start and stop like for half an hour. You can't expect that person to start all the 3 at 7 a.m. or close it. The opening and closing, if you stagger it by half an hour, and then they will be able to monitor.
Thanks, sir. My next question is to Mr. Jayaraman.
Yes,
it's about, I think you have answered very, I don't know whether others can review that particular answer. It's in the Q&A box.
We can view it.
Okay.
And he's answered it
the audience
excellently well.
Yeah. It's about single-use dialyzer.
I think Tyagarajan, the doctor, has already answered it.
Yeah.
But he has rightly answered, though he said it is the company's decision to do a single use. But slowly, I think in the near future, all the dialyzers will become single use only. So all will prefer single use, because the cost of the reprocessing or reusing for the patient, a lot of hidden cost is there, which we'll have to consider it.
Yeah. And I think you have elaborately, along with Dr. Tyagarajan, given the answer to that particular query, which is a very, very important question that has been coming up too often in an institute as well. I mean, thanks both of you for that. I'll move on to,
I would like to add one important point. Because I'm looking the statistics of the Indian economics and the SAARC countries' economics also. What I learned is how we have grown in the last 20 years of this hemodialysis population. In the beginning of till 2010, it was around like a 95%. It was a reuse only. But what is the present situation? What I noticed is still the reuse number is maintaining the same, and single use is also increased in the same number. That means number of patients growth is more. So because coming to the tier 1, tier 2, tier 3 cities, still in the below poverty economical people, it is not possible to go for the single use situation, even for the government also. So this reuse will be there for in the Indian population, as per my understanding, as per the statistics and financial document by the government of India, what they shows to us. So, but why I'm telling this point is whether everyone were interested for single use, and I were looking into the environmental pollution, how much it is going to landfill, everything we have calculated, but it's not going to be a big. But at the same time, the reuse will be there in the market only. Only thing is the standard we need to follow, infection control policy, how many times we need to reuse, what type of dialysis surface area we need to choose, that will be there. In my opinion, even next 20 to 30 years also, the reuse will be same amount, even though single use will be growing in the market, because that many population, we are dialyzing only 25% of the population in Indian market. Still 75% are not dialyzed. So even if the government is opening the opportunity for every below poverty economy, still the reuse will be maintaining. So only thing is that we need to have a proper systematic reprocessing techniques. That's my question.
Yeah, thanks. In fact, I wanted you to also take half a minute to conclude your presentation, sir. We couldn't hear you out in the concluding part of it. Yeah, if you can just give us summary of your conclusion, that would give us some closure to the presentation.
Yes, sir. I can share my last 2 slides only. I'll share my last 2 slides.
But so we have only half a minute.
yeah, half a minute. I understood, sir. I'm very, just I share my slides. I think the slides are visible, sir?
Yeah, it is. It is.
So, which I was talking about inadequate membranes and low molecule and delay in reprocessing. We should not delay the reprocessing. And improper use of cleaning solution, we should not use, especially like bleach solution, which needs to be carefully taken care. And improper handling of dialyzer, massive handling, very bad handling of dialysis should not be done. And finally, the slide will be very simple. We should not delay the process of reprocessing. Whenever there is a immediate case is over, we should immediately do the reprocessing and use the right amount of anticoagulation with the right amount, put 20 ml syringes. And priming is the most important for the dialyzer outcome, property, and everything. And we need to avoid air entry to the dialyzer. Even most of the time, air entry termination will be doing for reusable dialyzer. That should not be done. And use the adequate concentration of the cleaning solution appropriately. Sometimes over concentration will membrane damage will happen. We should not apply too much of pressure during the cleaning. Again, the membrane complications and issues will be more common. Use a biocompatible membrane. In Indian scenario, all our biocompatible dialysis membranes are common. So that's my last presentation. So thank you very much, sir.
Thanks a lot, sir. In fact, I would like to move on to Dr. Vinoy here. Sir, can you stop sharing the screen? Yeah. Dr. Vinoy, your presentation was absolutely marvelous. In fact, I was just telling my team as well on that. A lot of things, because clinical quality indicators are very tough to come by. And I think you have given us a lot of insight on that. One question, I think I'm going beyond that clinical indicator. I'm looking at you as a nephrologist who's dealing with dialysis day in and out. One issue that is coming up recently is about hepatitis C patients. And I think one of the audience has put up the question is that with the new anti-HCV treatment, most of the patients are turning out to be hepatitis C negative. So how do you deal with such patients, whether it's Hep C, and to some extent earlier it was Hep B that was creating an issue?
So, sorry. Here in Vellore, we for decades have been following dialysis on a zone barrier. We do not mix. Our zone 1 is totally viro-negative, PCR negatives. The zone 3, we treat them with viro-positives. With the advent of new antiviral drugs, yes, they do turn negative, but actually we do not shift them back into a negative zone because of the concern of the reactivation of these viruses after direct antiviral drugs. We need to follow up these patients who are receiving direct antiviral drugs, the new generation ones. because we have seen reactivation of this virus after 3 weeks. So what we need to look at sustained viral remission, which happens at 12 weeks, and then keep an annual follow-up. We need to know data on that. So we don't have the data, and we don't use it for our dialysis population. Secondly, for the fear of contamination and for the fear of cross-infection, we here in our institute, we have followed strict protocols even for the staff management. We have a very specific staff for all the 3 shifts for zone 3. They don't mix up with zone 2 or zone 1. So, and this has helped us to keep our hepatitis scare at bay. And we do a regular follow-up. Now, the only follow-up is what we are trying to do is doing a PCR test is quite costly. Like, and it's, how frequent are you supposed to do once you turn negative after direct antivirals on dialysis patients? That also the data is sparse. Now, the cost of the doing the dialysis, doing the PCR is also quite difficult for a patient. Definitely in a corporate or a private hospital, the rich will be able to, but when you look at poor patients or patients in the peripheral dialysis unit, it's quite difficult. So my simple suggestion is keep watching at least at the liver enzymes. You can have an anectic hepatitis. If there is a rise in the liver enzymes, the blood sample needs to be sent before you do a dialysis, not after the dialysis sessions. It can be falsely low. Keep a watch on them, have a regular monitoring with them, and that should be fine.
Thanks a lot, sir. In fact, that is a query generally raised in the lab as well as the dialysis centers, whether how to manage such patients. Thanks for your insight as well on this. I'll move on to Dr. Vibhu. Is Dr. Vibhu around? Yeah. I'll move on to another faculty, Miss Reena Santosh. Can you hear me, ma'am?
Yes,
yeah.
Yes.
There's one question that has been raised is which technique is preferred for patient cannulation for AV graft?
Yes, we don't have many patients with AV graft here. We say for the AV fistula, the angle of cannulation is when you put the needle, it is 45 degree and then changing it to 25 degree. For a graft, it can be more perpendicular than a fistula.
Thanks, ma'am. Thanks. And one last question, I'll put it to both Dr. Vinoy as well as Mr. Jayaraman. It's about endotoxin levels. RO, in a dialysis unit, we get RO water testing done, and invariably there are times when endotoxin level would be high. Dr. Vinoy, as a nephrologist, and Mr. Jayaraman as as a company executive with dealing with such equipments, what's your take on endotoxin level?
Usually disinfection is to be done once in a month, and you need to do the endotoxin counts. One, I did mention during my presentation, when it fills into the RO tank, mid-loop, and in return to the tank, if it is offline, you need to do all these places, including if there is a reprocessing bay, you need to have one count there, and in a bicarb mixer where the output is coming, you need to check all these areas for endotoxin count level as well as CFU once a month.
What if it comes positive? What do you do?
Positive, then you need to repeat. Positive means you have a level.
Would you shut the dialysis? Would you shut the RO plant?
Good question. My answer will be you cannot shut down, sir. You cannot shut down. You need to disinfect and you need to start. You cannot send the patient off, right? You need to disinfect the system and you can start it off.
I'm sure Dr. Vinoy will have a different opinion. That's why I opened it out to the nephrologist.
Please.
Yes, sir.
We do it monthly. And I can only tell you by God's grace, to be very honest, we have not had a positive value. Okay, so I have personally, I think Reena also, my colleague who's with me as well, can also chip in. We have not faced it. We faced at a particular inlet into an AK lab, that area. And then when we started looking into it, why only that point and the other points were not there, there are like these local point area of biofilms and things like that is a very important area that we should be able to check. As I told you, by God's grace, we have never had to face it of a situation of a culture being grown, but we do our HICC, the Hospital Infective Care Center, comes in for regular swabs that they do monthly. Reena should be able to also add in that. So, but we have never had to shut down. That is what I'm trying to say.
If it is periodically done, disinfection with the right disinfectant and right dwelling time, I don't think you will have any cultures in any of the inlets. That is one. Two, if it is done every time with the right disinfectant, it could be parasitic acid based, or people use still formaldehyde. I know few institutions in Tamil Nadu, they still practice formaldehyde. They need to have the dwelling time right. If it is formaldehyde, 24 hours. Though it is banned overseas, I have never seen overseas formaldehyde. Bleach means you need to have the right disinfection dwelling time. If this is done, your question was if it is positive. Usually I have not seen somebody. I had a question also. I said if the disinfection was right time done without any day skipping, what happens on a Sunday when disinfection is done? There is a breathing difficulty. They immediately drain and they start the patient. So the disinfection dwelling time is not adequate. That's the reason all these things creep in.
Sorry, correct me if I'm wrong. I'm Dr. Prabhakar. I think formaldehyde is banned even in India.
But still some people are still using, sir.
No, but can others enlighten this with? Because formaldehyde is banned in India for a long time, I think. So correct me if I'm wrong.
I think I think we are running short on time, sir. I'll put that question on the group and we'll move next to the first. Before moving on next to the next session, I'll thank all the faculty members for joining in, for being part of this, despite starting very early at 3 p.m. And all of you have been part of the expert panel as well, answering all the questions and all the queries that were raised by us as well as the audience. Now we move on to the quiz master for the day. Dr. Anna George, please. Thanks, everyone, sir.
Thank you.
Thank you, Dr. Subin. Thank you, esteemed panelists. I think I just enjoyed my day so far. I hope all the participants have really had fun. A lot of educating moments, a lot of knowledge shared. So thank you all.